Okay, so I will get started by introducing the webinar, and then I will turn it over to you and Michelle. Okay, so good afternoon, everyone, and welcome to the second educational webinar for NMAC's HIV 50+ program. My name is Joanna Lopez, and I'm the program manager at NMAC, and I'll be helping with the logistics of today's webinar. On the line, I also have my colleague Sable Nelson that will be helping answer any questions in the chat box. So today's presenters are Dr. Stephen Karpanak and Michelle Lopez from the AFRA Center on HIV and Aging at GMHC. They will be presenting on sexual health and HIV and aging. They will be taking questions throughout the presentation and after. We are recording today's presentation and it will be emailed after the webinar to everyone who registered. I will now turn it over to Dr. Steve Karpanak and Michelle Lopez to introduce themselves and begin the presentation.
Okay. Good afternoon. This is Steve Karpiak.
And this is Michelle Lopez, both from Korea.
And we are at GMHC these days. So we're going to present this together. And please ask questions, and your monitor there will alert us when you ask. We're going to try to cover this very broad issue about sexual health and HIV and aging, and trying to cover it from a positive viewpoint. One of the best organizations that defines anything, but in this case sexual health, is the WHO. And I'm not going to read all of this, but I'm going to read the last one. It says, for sexual health to be attained and maintained, the sexual rights of all persons must be respected, protected, and fulfilled. And the importance of that comment is, or that definition is, that sexuality is a highly varied behavior. By the way, all sex is learned. Not attraction, but is learned. And everyone has their own sexual interests, right? And I always tell people that they should visit all the rooms in the sexual mansion, okay? Visit them at least once, and you'll find out if you like it or not. And that all sex is not just insertive sex, sex for the purpose of procreation, but there are many, many forms of sex, as one knows, in the human domain. So, we're talking about HIV and aging today, and there are two reasons why we talk about this at all. How did we get here? Why are there so many older adults living with HIV? The primary reason is highly effective antiretroviral therapy, which began in the middle 1990s, and today we have many, almost I think close to 40 different antiretrovirals that a physician can choose from. So there are many, many ways to suppress the virus and to live a long life. But there is a secondary reason, and we're going to talk about that today, and that's the new infections that occur in older adults over the age of 50. Now, these are not huge numbers, but they're significant numbers, and they're often overlooked. And even though the CDC focuses on certain groups, one group they have never focused on is the older adult. So there are all kinds of perspectives as we go through the day today, and one of them is that there are differences between men, women, between your sexual identity, etc. And it's important to realize that, because one size doesn't fit everyone. So, for example, as women age, they tend to have a lower libido, vaginal dryness, and often experience pain during sex. Most males don't report that, obviously not. We also know that most males, particularly MSM, live alone, and who are over the age of 50, and they are not in relationships, stable relationships. You'll see later on that most of the data generated in older adults as regards to sex are generated on the heterosexual population, where most people are partnered. But in this case, for the populations that we are most interested in, that's not the case. Okay? Here's a good example that also we're going to talk today not just about HIV, but STIs. There was an increase by as much as 30% in chlamydia in women over the age of 65 in this country, which is a huge increase. As a matter of fact, if you look at almost any measure of STIs in this country, as well as Europe, Canada, you'll find that in the older population, STIs, which includes HIV, are on the increase markedly and significantly. On the left side is a bar graph, and it shows you who are the people older with HIV that we're talking about today. The vast majority, or 50%, are MSM, 12% are IDU, injection drug users, 15% are heterosexual men, and 25% are heterosexual women. And when I talk about HIV and Asian, and I often give these numbers, a lot of folks kind of say, well, where do you get all the heterosexuals from? And the reality is they forget about women. Women are as much part of this equation as any of the other categories we mentioned here today. So sexual health. Remember, this is not about just prevention today. We're talking about sex is part of your health. As a matter of fact, if you go into the literature and you look at it carefully, and you hear more about this later from Michelle, there are lots of reasons why one should have sex. Okay? Not just to be happy, okay? Not just to have children, but there are all kinds of health benefits that are derived from having a good, healthy sex life. And a lot of us don't realize that, or it's never really taught to us. So sexual function changes as we age, of course. Sex hormones drive a lot of these behaviors, and it becomes longer to get aroused or achieve an orgasm in men, as well as women. We know that as you get older, it takes longer for men to get an erection, and for women, vaginal dryness is a common issue. Now, getting an erection makes us think about the enhancers for
Viagra
and Cialis or whatever, and which is great for the men, not necessarily for the women. There's no substitute for that. And I think, as many of you might know, these are actually rather expensive drugs, by and large. So they may be there, they may be accessible, but are they affordable, or does your health policy cover them? The other thing that can limit sexual activity is illness. Okay, function. If you can't function, you're not going to want to have sex. And we all know those days when we feel kind of miserable, even to just have a lousy cold or flu. Well, those are not the days that we opt to have sex. So realize that, and realize that as people get older, they have more and more conditions. And we know that's especially true in the older adult with HIV, having multimorbidity. And those illnesses get in the way of being motivated for or having sex. This doesn't mean it stops. But even if someone has an injury, or could be loss of use of a limb or disability, people, even in those conditions, still have the desire to want to have sex, particularly if they are partnered. One of the most important things to remember in this data today is that most of the studies on sexual behavior, on sexuality in the older adult, assumes heterosexuality, and it assumes they have partners. So what the literature shows is that as you get older, yes, sex decreases, but it decreases because people lose their partners. Partners die, they get divorced, they pass away, or the partner is so ill the person can't have sex with them anymore. And these often can cause issues, but nonetheless, it's accessibility to a partner that really defines the ability to have sex as one gets older. Now, in some cases, for example, I'll allude to African American women, the ratio for all women to men, there are more women than there are men. Even at birth, more women survive birth than males. Women are the more fittest of the species, by the way. They're the ones who live long enough to put their husbands away. So, but example, in the African American community, the ratio of women to men is really very high because men have been incarcerated or had succumbed to violent behavior in their community. So the woman has fewer partners to choose from, and the man, if you will, is in the driver's seat. I've given this presentation at nursing homes and assisted livings, and inevitably in the room there are 30 women and one man. And if that one man has a car and Viagra, he's in business. So the ratios are really rather skewed toward men and not women as a benefit. Sex is an important part of healthy aging. I don't think any place anywhere actually teaches this phenomenon. You never hear lectures, you never see things on TV, you never show that it's not just having sex as you're older is looked upon like, oh my God, golly gee whiz, people still do this. But it's also a very positive element of being healthy. And this is a message that really doesn't get through very well in the context of HIV, but especially in in our society. Now, just to harken back to HIV, these are some numbers to let you know why we're even here today. The number of people with HIV increases over the age of 50 every single day. And here are some numbers from particular cities and states. You can see that San Francisco is at 64%. Actually, if you look at the data today, it's around 67%. New York City is about 60%. But nonetheless, these numbers give you an idea that the vast majority of people living with HIV in the USA are age 50 and older, and that number increases every single day. So that by 2020 or a little bit thereafter, 70% will be age 50 and older. The reason these numbers are important is that as much as we who've done research on this, myself, Michelle has been part of this effort for many years, people still don't realize this. People don't understand that the epidemic is now dominated. I can't use that word enough. Dominated by the older adult. Everyone counts, young and old, but the older population is growing by leaps and bounds. 2 weeks ago, I was in Washington for a conference on rewriting the Ryan White Care Act, and it was kind of amazing that only recently have those folks who manage that Care Act come to the realization that the needs of the older adult are dominating here, and they go far, far beyond viral suppression. So here in the USA, there were, in 2017, 38,281 new HIV infections. And I think we all know we want to keep getting that lower and lower. Okay. Of those, 6,513 were in older adults, age 50 and over, 17.01%. Actually, it's been about 17% for the last decade, and it really hasn't changed very much. Interestingly, in the other age categories, let's say from 20 to 30, 30 to 40, 40 to 50, it's actually gone down, but not in this category. It's actually stayed the same and maybe increasing. The number of new AIDS diagnoses in the USA last year, in 2017, were 17,604. This is too many diagnoses of AIDS. This means people have been living with HIV infection for too long, and it progresses to AIDS. I mean, we've missed testing them, and we've missed connecting them with kids. This is not good, not good. And of those, 5,298 are in people over the age of 50. That's 30%. 1/3 of all AIDS, new AIDS diagnoses are in the older adult. These are not small numbers, but I must say once again, the larger population out there of caregivers and government folks miss this data. For some reason, they're not seeing it, but we're making progress. In this slide, I wanted to show you what it means to have cases of HIV versus rate. And in many ways, it's the CDC looks at rate, not case numbers, but numbers are a function of where you live, how many people live in your city or state, whatever. So here on the left side, okay, who has, in this case, I'm going to show you the number one number in a second, but you can see that California had in 2016, 830, Texas 638, down to Jersey, which was 240. If we look at the top number, and you see that Florida had the most number of new cases over age 50, 938. And if you look at the rate, the highest rate, I believe, is in your home district, DC, 39 per 100,000. That means there were 39 cases of HIV over the age of 50 per 100,000 population. That number is equivalent to sub-Saharan Africa. And then you can see here that Georgia, which was number 5 on the list, 399, but is number 2 on the list here, or Florida, number 1 on the list on the left in cases, but number 3 here. So you can see that the rate is really important, and it tells us the density, if you will. That if you live in a small city and you have a high rate, that means you have a higher chance of encountering someone with HIV. If you live in a big city where there are many more people, your chances are fewer. But also that depends upon how you select your partner and for sex, etc. But these are important differences when you look at data, that the rate is really important. And here, DC, which has actually done a great deal in bringing down their infection rates, but they're still very, very high for a very high density population. Okay, so at ACREA, we are now based at GMHC. We're a program of GMHC. We have the longest funding HIV prevention campaign in the USA. We've been doing this for years. Okay, and when we started 12 years ago, we were kind of babes in the wood, but we've learned a great deal. And we're able to do this with funding from the New York City Council, which in the beginning was almost $1 million a year, and that's since gone down. And in the beginning, we went out, our trainers and the people who manage this program, and they went out to every senior center in the city. There are 365 of them, by the way, and they attempted to talk about this issue to their seniors who attend those particular agencies. So we've got a lot of experience. And as many of you might know, every single year we start a new campaign, and that new campaign is defined by the images that we generate. And every year they'll change. Sometimes we get a little bit more risky with them. This is all done under DOH's eye. But many of you know this. This is a combination, a kind of a melange of the images we've used over the years. So the website or a Facebook page that you can get more information on HIV and aging and sexuality is Age is Not a Condom. It's a very interesting story about that phrase. I was in London lecturing, and there was a young man who had just come over with a Fulbright scholarship from Princeton. He was about 23 years old, and he was in the audience, and he introduced himself to me and said, I'm working on the same issue. And I said, oh, great. And I watched his presentation, and it was phenomenal. He was a young man dealing with an issue that is for older adults, and he created this wonderful campaign for the UK about HIV and aging, and the name was generated by him. Age is Not a Condom. He's a great graphic designer, and he let us use this phrase from now on. So, and that's the name of the site, Age is Not a Condom. You should go there. Not only are there great images there, but there's a tremendous amount of information there. There's toolkits, and that addresses many, many aspects of this, which we're only going to touch on today. Okay, so I'm going to turn this over to Michelle. I'll jump back in, but we're going to talk about the positive elements of sexual health.
So, ladies and gentlemen, do you believe sexual activity stops with aging? So what do you think?
Yell it out.
Oh, hold on. Somehow we got pushed out. Look at that. I asked a simple question.
If all else fails, we do hand puppets there. Okay. Okay.
We had a little bit of technical difficulties going on here. Okay. So I'm going to ask the question again. Do you believe that sexual activity stops with aging, right? And the answer actually really is no, right? We know sexuality has long been, this is a myth. It deteriorates inevitably with age. What we have found is that health is more important.
It feels good trying.
Hello?
Okay.
Hi, we're still here. I think, Steve, do you need to accept presenting your screen again?
I'm sorry, could you repeat that?
I think Steve needs to accept presenting his screen. We lost
No, I'm using the same screen. That's the thing. Hold on. Uh-oh.
There we go. We're all set.
You got it? Okay, so I'm going to go back.
Okay.
So should I go back from do you believe sexual activity
I want to hear them.
stops with aging?
Who says no?
Yes.
Anyone says no? Hello?
Okay.
Are we out there? Okay.
Everyone's muted for everyone.
Just press on. Just press on. Press on.
Okay, dear. I'm going. All right. So we're looking again. Although sexuality has been thought, there's this myth, right, to deteriorate inevitably with age. That's a myth. That's not true, right? What we found is that health is more of an important indicator for many aspects of sexuality. And this is not just by age alone. And this has been studied by Ms. Stacy Landau at the University of Chicago. She's a professor there and someone that is doing an extensive amount of work with us. So let's look at this graph, and it looks at social life, health, and aging, and it's a sample of over 3,000 individuals. And what are we seeing here? What we are seeing here is that, guess what? People are still sexually active even up until 85, right? So, the proof is in the pudding. We have the data here. These are some quotes now. I want us to look at, these are quotes that are actually coming from social workers at the senior centers. We spend a lot of time and doing our work, and these are some of the vignettes that we captured, right? The social worker says, oh, they will never want to talk about sex. It's embarrassing. That has not been my experience because I go out to the senior centers and have these facilitated discussions. We only have 2 married couples in the center. These are vignettes, again, that we captured from social workers as we continually, go out there into the field providing these sexual health educational programs at senior centers. So it's an ongoing method that, again, we have these providers thinking this.
So before we start this video, when we went to senior centers, we found that the people who run the senior centers were very reticent to have us come in and talk about prevention issues in HIV. But the people who actually go there, they said, no, we want to hear about it. And I think one of the best telling signs of this is that we asked every senior center to put out a bowl of condoms, and we all give out condoms. Well, at the end of the day, they were all gone. And it wasn't staff who was taking them; it were the seniors who attended these programs in senior centers. So they're a great resource. They need to be educated, and it's really, even when I've been asked to go to nursing homes to give this almost similar lecture, what I find is that when I start, everyone's attentive. When the senior staff leave, then everyone wants to talk to me. So it's really the person, the senior, knows very well what's going on and is really very attuned to this. But somehow the people who manage them think it's not. Now let's see if we can get this to go here. Hold on.
We're going to play a short video.
If it'll play.
Let's go back.
Go back. Sorry.
Okay.
Bear with me. Where's previous? Okay.
There we go.
Okay. Wait a minute. Okay.
Humbled to be in the room. I can hardly, how did you not mention this? You can't see anyone. I can hear you all in the back of the room, but I'm certainly humbled to be here in a room full of tremendous people and physicians, all of us who share a passion for what we do for our patients every day. So we like to tell stories, although it occurs to me as physicians, we oftentimes can't share our stories out of respect for the confidentiality of our patients. But tonight we're sharing. And my story begins actually as a medical student at Brown University. I was visiting there yesterday. In medical school, we learned that we should take a sexual history from patients. Do you remember the history and physical examination course? And your teachers would check with their patients to see if you could stop by and practice asking all those questions and doing the physical exam. And at Brown, the teachers were geriatricians. And they told us that the sexual history was just part of the regular history and everybody should ask the questions unless there was a very, very good reason not to. And age was not a reason to not ask the questions because the geriatricians were real advocates for the older patients. So I went off to Rhode Island Hospital. This made sense to me, by the way. I didn't find it particularly shocking or unusual. Went to Rhode Island Hospital where most of the patients were older men in hospital gowns, sometimes 2 or 3 to a room, not looking particularly happy, not feeling well, of course, because they were in the hospital, and now doing a favor for their physician to answer the questions and be examined over and over again by medical students. And it was at the point in the history where I said, well, and do you have a sexual partner? And what's that like? And how's your sex life? Where the man went from being a sick older patient to a person with a twinkle in his eye and a story to tell. I thought this was very interesting and exciting. And as a medical student, all we want to do is something that makes the patients feel better. And usually we're just superfluous. We have no role. We're aggravating and annoying. But it seemed that asking the sexual part of the history was a way to connect with people. And it became an interest for me for my research. So fast forward a few years later, now I'm a resident in obstetrics and gynecology here in Chicago at Northwestern Memorial Hospital. I'm on call, I'm taking care of patients on the gynecology oncology service. And it was one of those nights where you can see maybe you're gonna get some sleep. So I went to the 14th floor and I thought I'll tuck in my patients. You have this idea if you just tuck them in, then everything will be okay. And I stopped in to see Mrs. Jones, we'll call her, who was there. Her family had brought her in. She was really at the end of her life with endometrial cancer. And they brought her to the hospital for us to help her die in peace. And I said to Mrs. Jones, if something should happen to you tonight, Tell me, what should we do? Who would be the person to call to help make a decision on your behalf? And her son stepped forward, and he had his business card ready with his phone number, and he said, if anything should happen, you should call me. And I sort of surveyed the room, including Mrs. Jones, and I got the assent, the heads were nodding, and I thought, okay, this is fine. I tucked it into my pocket. I said good night, and of course, let's hope it'll be a peaceful night. And I went back down to the call room, and I took off my pink, dirty clogs and left them by the door, got into bed, and the phone rang, and it was the nurse from the 14th floor, and she said, Mrs. Jones' family has left, and she'd like to speak with you. I went back to the room, and she was holding another piece of paper with another man's name and a different phone number. And she said, Dr. Lindau, something should happen tonight. This is who you need to call. So I said, well, who is this? And she said, well, my family knows him as my next door neighbor. But I've been a widow, Dr. Lindau, I've been a widow for a long time. And this man is my companion, he's my partner, and he's my lover. And my family doesn't know that. But if something should happen to me, he's the person you should call. So I said, well, let's hope it's a peaceful night. And I went back downstairs. Of course, there was no more sleep. And I felt a terrible ethical dilemma. And in fact, working with the McLean Center in Clinical Medical Ethics at the University of Chicago has become part of my pursuit to try to understand the ethics of caring for patients. But I thought, this is really unfair. This woman, here she is at a critical moment of her life, really the end of her life. And she couldn't even share with her family the fact of this person who she wanted to make the most important decisions for her. She couldn't share that relationship, and nor could she gain the full benefit of that relationship. And I started to think about how sexuality was related to health, not just through the transmission of disease or pregnancy or the pleasure that makes us feel healthy and well, but also how important our intimate partners are for these critical moments in life. So fast forward a few more years, and we conduct a national study on sexuality and aging, and we publish it in the New England Journal of Medicine. David Letterman makes it his top 10 that night. So clearly I've peaked, but really the peak moment was when Dr. Diane Yamada, who heads the section of gynecology oncology at the University of Chicago, said to me, the research you're doing is great. Can we bring it to practice so that we can improve care for sexual issues for our patients who have cancer? So you've had a few minutes to think about it, and so those of you who don't take care of people with sexual concerns or cancer might wonder what the two have to do with each other. But I think if you think about it for just a second, you realize that the vast majority of cancers, women and men survive, are those that directly affect the sexual organs. Prostate cancer, breast cancer, gynecologic cancers, colorectal cancer. And for men, if we look at prostate cancer care, we've come a long way, and prostate cancer care sets an excellent example of how physicians can openly talk with their patients about sexual issues and can say to men, if you choose option A, this is what you can expect for your sexual function, and for option B, you could expect this. Unfortunately, for women's cancer care, we're further behind. Cancer doctors need to cure cancer, and that's what patients and doctors, when we're facing these scary times, really need to do. But addressing the issue of sexuality and giving women information so they can know that if they experience a problem, it's not just in their head. It might have to do with the treatments, like the removal of the breasts or the removal of, or radiation of the genital organs, or it might be due to the drugs that we give them. So patients know they're not alone if they experience these symptoms, that it's not just in their head, that it's not just that they're not trying hard enough, and that we can be there to help them. And that's what our program has been about. I want to end, since we like stories so much, with inspiration for me that comes from great American fiction. Ralph Ellison is a fiction writer who wrote a book called Invisible Man. And he talked about the invisible and the invisible. And we've seen that medicine brings us ways for seeing the invisible, X-rays, CAT scans, and microscopes, things we can't see because of the physical limitations of our eyes. But for me, and if you think about it, I imagine for you, our patients show us about the invisible, things that we don't see because we don't want to look down there, things we don't see because of biases or prejudices in our society. And to me, one of the great privileges of being a physician is learning to see the invisible through the eyes of my patients. Thank you very much.
Thank you, everyone. We're going to proceed.
Oh,
Here we go.
okay, make sure my screen is on.
Okay.
Is it there? Okay. Okay.
Okay. Okay, so we're going to touch a bit here. Yes, I think it was a good segue. It's just, looking at our role between provider patient, and we're going to segue into looking at cardiovascular risk and sexual activity in older adults. There is a relevance when we look at that because, again, I think another bias, cardiovascular disease diagnosis does not say that you should stop having sex. So we look at these.
And I might interject, the reason we picked cardiovascular disease is because in the older adult with HIV, this is the number one risk disorder, risk morbidity that they have. The risk for cardiovascular disease is increased within the HIV population. If there's any comorbidity that's increased, it's clearly cardiovascular disease.
But my appeal, if we look at the second dot, my appeal goes out to women. Good sexual quality. What it does, we are seeing a protection there for women in reference to the risk from cardiovascular risk. So clearly, again, from what I'm hearing, good sex is going to be good for the girls and our heart. So there is no evidence also to, again, there is no evidence. We want to, we look at the research that poor cardiovascular health, it does not. In fact, it helps sex with the person. And later, when you look at also to sexuality with either gender, cardiovascular diagnosis, it does not interfere.
Yeah, and Michelle, the point here too is that you can do things for yourself that are not pill related. Every time you put a pill in your body, you pay a price for it. And sometimes we certainly have to do that. But there are things you can do for your health in general that can improve, in this case, decrease risk for cardiovascular disease in women. Men don't benefit from this, by the way.
Exactly. Next slide. Okay. I'm segueing into testing now because I really want to also too, there has been some wonderful outcomes. Checklist is one of the, what we would say, tools that we have in the toolkit for our over 50 educational program out there. So one of the things that have successfully happened whenever I go into any of our senior residencies, senior homes, I go with my checklist card. And I go through explaining and having the discussion with seniors in reference to knowing your status and why it's important. I'm going to share an experience that I had for 1 year consistently because of me using this card with seniors in the discussion. I pretty much had what I would say my follow-up. I always say to my facilities, I don't do one-shot deals. So who I got engaged in conversations with me, they took this checklist card and literally took it to their providers and asked their providers the main thing, how come you never offered me an HIV test? I literally got a response. Let's say I'm going to use a number, must have been about like 35 of the individuals did point that out to me. Out of that 35, every one of them said their doctor told them, well, you never asked me. The doctor was saying to them, right, you never asked me or you never mentioned to me that you want to have an HIV test. The rebuttal from the clientele that I spoke with says, well, we were not even aware that we should be having an HIV test because, and every one of them were over the age of 60. So what we have looked at also too, going back, if you see in reference to testing as of 2015, adults over age 45, over the age of 45, do account for 28% of the new infection. And I think this is where we are looking at the concurrent diagnosis of AIDS and HIV when a person over 50 or senior gets tested for the first time. These are some of the nuances that's popping up. So I think, again, we really do need to have it where we can speak to seniors who are presently having sex and also to who have had a sexual past. Because we do know HIV can remain, within the body within, a 10-year period before it even starts showing, these different manifestations of AIDS. So we then look at testing, and I really do want to keep the focus here now on testing for older adults. We do know CDC have recommended right, from ages 13, and I believe they had it at 64. But here in New York, we have not capped it. 13 and ongoing up, should be tested at least, because this is how we want to be able to routinize. Again, we are putting it in writing, but now in order to enforce it, we are looking at these are some of the areas where we can improve. Don't make assumptions about the risk of sexual activities, right? Again, it's a conversation in a not judgmental way that we want to be able to facilitate, right? Verbal consent replaced now with written consent. And I have to say it again, our OBGYN providers, I spend a lot of time in their offices now speaking to them, even not just for HIV testings, but the importance for STI screenings also, right? And as we saw earlier on, there was such an increase in reference to chlamydia with the older, with our senior population. So there are different types of tests. We do know that.
And also, education is needed both of the provider, the physician, which many of us would not think is the case, okay, and as well as the client. So this is a two-way street. And in many respects, the physician is the one who needs more training. Curiously, in New York City, 70% of all diagnoses of HIV over the age of 50 occur in the ER, okay, which is really a bit late to have this test. So we need a major education effort, and we have done it, but it needs more in our society.
Next slide. Okay, so what is the issue that we are dealing with here? Right, we are dealing with ages. We know it, and older people, again, the myth, right? Ageism. People are under this notion older people do not have sex. When we know, again, right, older adults, they are becoming infected. The same method. They are doing the same things that young people are doing to become infected, right? And providers, again, it's my appeal to the providers in reference to having this discussion, because if we're hearing, from, so many of the seniors who are sexually acting saying, look, I know what I'm doing, but my doctor never asked, who's waiting to approach who, or who is taking, for me, looking at good public health, the accountability of ensuring I'm having these discussions, with my clientele.
Yeah, I might interject. I've been asked many times to go to nursing homes, and usually if you're in a nursing home, you're disabled, right? You're not exactly running around the block. But when I've given lectures on this over the years, when the supervisory staff leave the room, the line staff start discussing all the sex that's going on in that nursing home, which would, I must tell you, shock you. Okay, and it's consensual. It's not unconsensual, non-consensual sex. It's really the need to have sex is really quite considerable. And I always tell the study, I'm a neurobiologist by training, and you've seen those classic experiments where if you put an electrode in a rat's brain, and one is in the center where they stimulate the eating center of the brain, and the other is in the sex center. And if you give the rat the option of pushing the lever to stimulate the eating center, meaning they feel like they've eaten food and they're happy, or versus the sex center that causes sexual stimulation, the rat will press the sexual stimulation lever until it drops from exhaustion, so that having sex dominates even eating food to stay alive. It's a very, very powerful drive. And for those who say, well, you can just say no, okay? I don't think so. It's like saying no to sleep. It's almost impossible to do that. It can be done, but in rare instances. The power of sex is not to be minimized.
Okay. And as we know, I'm going to keep saying it again, sex is important. Right? There's wonderful things, clinical outcomes because of sex. So although sexuality has been long thought to deteriorate inevitably with age, what we have found, the science have found, the research have found that health, is more important. It's a more important indicator for many aspects of sexuality than our age alone.
And this picture we chose for a reason. These two guys here are holding hands. And there's clearly a relationship between them that you see in the picture. All sex is not insertive, right? All sex is not aimed at reproduction. All sex is not vaginal or anal. Some sex is just holding hands. And for many women especially, this is what they seek out as they get older. They're looking for companionship, and that alone is a form of sexual activity. And we should consider it as part of the sexual health of any individual.
That's right. Okay, so let's look at some benefits. I'm not going to go through every pointer.
You should take notes
But
here.
I really want us to take notes and, again, grab the cap where it fits you, right? But I also, too, a lot of times, again, when we're speaking about the over 50, living with HIV, having to deal with loneliness, having to deal with, the depression, having to deal with stigma. Right. One of the things that I have seen also too, and I've heard quite a lot, is the insomnia issue that is happening with, some of us. So here, Dr. Karpak and myself, we put together this list so that individuals and again, providers who are working with this population of us, really can give them. These are the benefits. We tell people what's the benefits, and we're working with people, having undetectable viral loads. We know about you equals you today. Well, guess what? For individuals, who is getting that rejuvenation of life, sex might just be one of the factors. It helps improve good sleep after an orgasm. There are hormones, right? Prolactin and serotonin, that gets released. Women argue. Women can say that, after an orgasm, I literally felt as if I gained back 100 T cells. So some of us can speak from experiences and we share it, right? We know, again, what orgasm does, right? It releases that hormone, right? Oxytocin. Oxytocin, right? It promotes, and this is what it does. It promotes a feeling of well-being and happiness. And for me, this is something I think every provider should tie that into some of the tools that we're giving people.
By the way, it's oxytocin and prolactin, the hormones that are released when a mother is breastfeeding. And those two hormones are in part responsible for the bonding that occurs between the mother and child. So now think about two older adults or adults of any age. These hormones are still released, and they also are part of the bonding process that occurs between those two individuals.
Right. Again, I think also too what stands out here for me in reference to this list. Again, I'm a woman, so I'm really speaking, on this. Women also too have said in research they had, when they had these frequent, extremely satisfying sex. It actually, one of the clinical outcomes, a lower risk of hypertension. And what this is really, when we're looking at it, if your risk is lower for hypertension, it's a really common, precursor to heart disease. So we are looking at it again when I talk about, and I think the doctor mentioned it earlier on, may not be everything is going to be about a pill, but there are some natural, wonderful things that we can engage in.
We also know if you look at the third item from the top, that sexual intercourse in men and women has that's satisfying, also minimizes or ameliorates some of the mental health issues that people have, especially depression. This does not include masturbation, by the way, unfortunately.
Unfortunately.
In fact, if you go to the last one here,
yes,
if you can see that those who have frequently have ejaculation by masturbation, at least on a monthly basis, that those folks have a reduced risk, not elimination, for prostate cancer.
Okay.
So there's a good reason to do that.
So we got to help our guys. We're going to help our guys. Next slide. Okay, and here we go. We have, again, looking at some more benefits, right? Sex may help your memory. How many of us keeps, I got to say, I'm struggling with that right now. I'm having a really hard time with a lot of my cognitive, even memory stuff. So we looked at it. Also, too, here we have information that shows men over 50 who had more sex, they were better at word recall and number sequencing. So, hey, share the wealth. Let our guys know, that these are things that sex can definitely have a wonderful outcome.
Now, we're not saying it prevents the dementia, please, but at the same time, on day-to-day living, it clearly has an effect.
Mm-hmm. Yes, indeed. I think again, I'm looking at this hormonal release, the oxytocin, because of these feelings of well-being. We had a study done of over 30,000 American men and women, and this, found that having sex at least just once a week, in a committed relationship was enough to make people happy. So they're saying that, here again we have the finding. Once a week may just be sufficient, and it can definitely have some great outcomes.
And even it's been shown that frequent sex also results in boosting your immune system by increasing the immunoglobulin A antibody, which is a functioning antibody, and it's your first line of defense when an infection occurs. So once again, these are not panaceas. These are not going to cure anything, but they improve your health. As you get older and you have aches and pains and you have this various number of comorbid conditions, you'll find that every little bit helps you feel better that day. Anything that improves your health, even in a nominal way, it can help you a great deal. Now, by the way, the last one can sex be a form of exercise? Yes. Okay, if you do it for a long time, more than 30 minutes.
Okay.
If you do it for 3 hours, you're in business.
So I'm writing scripts for over 30 minutes of sex.
Right, exactly.
And it serves.
In other words, it's not a quickie that works here.
Older women. I'm gonna now, speak because I've really done an extensive amount of work. Myself as an old, woman that's aging and also working with peers in a clinical setting, and we have looked at it when we pretty much what are the issues that we are seeing here with older women, right? Older women may be at heightened risk for HIV and other STIs just because of the natural changes that occur after menopause, because there are some serious, changes that's going on there. Use condoms, right? We don't use condoms, right, as a birth control because we're not worrying about that. Postmenopausal again, right? So when we're looking at it also too, there are, there needs to be again that support in helping them in reference to condom negotiation. Because some of us, after a period of time, had made a choice of not being sexually active. But when we looked at the impact and the increase of the sexually transmitted infections that is happening, with women, as we know, they're not getting it by themselves. So here again, there is a need for working with older women and condom negotiation skills, right? So what I want to do here actually in this aspect of it is just again, to have a discussion. Please feel free to chime in, to give a response in reference, to, so when we look at it in reference to our current culture, when we look at sex, right? And I'm talking from the perspective of someone sex positive and also too, or if that person chooses to be negative, they're not having sex. We also too want to be able to have individuals, has it swung too far in one direction? We are looking at these, reality. Has society's message, right? We have put out these different messages about sexual behavior. Have this now made, have an impact on our long-term survivors and, their own ability, right? Some of us are in discordant relationships now. Some of us, because of, our sexuality and chooses, we are back in same-sex relationships, outside of, cis and heterosexual relationships. So we are looking at it now. The sex positive is, yes, sex is good, it's natural, it's healthy. When we look at the negative aspect of it, we still are seeing the messages out here. Sex is bad, it's dirty, it's wrong, it's sinful, right? So when we look at having these discussions, where do you fall on the spectrum? Is it a yes? Is it a no? Any feedback?
Let me chime in now.
Yes, please do.
Sure.
Hi, my name is Brian Jones, and I've been thriving with AIDS for 35 years. I think the conversation, if we reflect back to the Denver Principles, back in 1983, where they said we have a right to a healthy sex life. So it was almost like they were psychic and knew that this was going to be an issue. I think there's a couple of points. I think one, with the language, we have to look at the language, because I noticed when you talked about heterosexual men, but you call same gender loving men MSMs. And for me, that's a problem because it reduces everything they do. It used to just to point out a behavior, but now it's become an identity. So I think it's a problem as we try to educate young men, because everything they do now is just reduced to sex, and it rules out love. I mean, you can have sex with somebody different every day, but that doesn't discount the fact that you might be looking for love. And another thing is that a lot of people living with HIV really don't know what a healthy sex life looks like to begin with. I think it's, a lot of times we put a lot of everything in the HIV basket. I think we have to take some ownership of where it is. And sex is not pleasant for a lot of people. I think another thing is disclosure. And also another thing is many still don't believe in U equals U. And the big tester thing, Black people believe in being health sick, not health care. So a lot of those over 50 people coming into the, we know that they probably were late testers. They might have contracted it. And because of HIV criminalization laws and because the light shows up, they just didn't want to get tested. One more thing. Okay, another thing about the cholesterol and all those numbers. A lot of people are just food challenged. I think there's some, for Black folks, there's some overarching social and structural disparities that impact HIV and AIDS. And also, for sex to become important, you've got to have some value or receive some value from it. And a lot of times, the ASOs and organizations are not doing things to empower us. We used to have secondary prevention for people living with HIV, and they don't have that anymore. So those over 50 populations are being left behind. Said enough. Thank you.
Thank you.
Thank you, Brian. Yeah, so I guess, I think it gives me the premise to say, being sex positive, these are the areas that we're going to have to, start doing some work, because as long-term survivors, we're going to be here until we're not here anymore. And for those of us who are, who's having rich sexual lives, okay, we're on the sex positive.
Thanks, Michelle. Sorry, I don't mean to interrupt it. I just want to point out the time that it is 3 p.m. I know we started late, but I just want to give you the option to have questions to answer. So I'll give you about 5 to 10 more minutes.
If there are more questions, please ask.
Yes, we're moving on because we are wrapping up to the end.
At the end here. So,
yes.
Just hearing our questions.
So
I'll make a comment. I am not a positive man, but I am 72 years old. And I remember growing up as a gay man in the 80s and before that. And we found out about sex by having sex, by having different partners or the same partner. Mm-hmm. And yes, of course, we looked at magazines and pornography, but it wasn't that accessible. We didn't have a web then in those days. And when I meet every year, I'm assigned a group of students that I interact with as a mentor here at New York. And what I find is that most people's expectations about sex come from pornography, which is omnipresent. It's available easily online, free. And the reality is that what you see in pornography has nothing to do with reality. If anyone knows anything about porno, it's made over time, that every person who's involved in it, who has an instant erection or orgasm on the part of a woman, you know what? These are professionals. This is why they do it. And they give actually a bad message to those of us, the commoners. So I think when you have a chance to interact with younger people especially, just ask them to get a reality check, that everyone can't do what you see on film. God knows.
We are open for questions or comments.
When you give out this PowerPoint, we skipped one other video, which was a scene from Scrubs,
yes.
The TV series Scrubs, and it's a very funny one where the physicians are running around like chickens with their heads chopped off because no one wants to go into the room where there is Mr. and Mrs. Smith, who are about 80 years old each, married, and both of them have come back with an STI diagnosis.
Syphilis.
Yeah, and they can't. The doctors can't talk about it with them, and yet the two people are very comfortable. In fact, you find out that they're both swingers. Mm-hmm. But be that as it may, there's more that goes on out there in intimate lives that any of us can imagine, and we need to understand and, very importantly, be accepting. The thing that I hear from patients that I work with in research is that when they encounter a physician who, by word or by simply movement of their body, become judgmental about the person. As soon as you do that, you close all kinds of doors to communication, to even returning to that physician for health care. It's, for those of us, and I'm sure most of you who work in the HIV world, you know that from day one, you cannot be judgmental, or you just close the patient in front of you, will no longer engage with you. But it's fascinating that for physicians, as well as other healthcare providers, they don't get this message. They don't understand how important it is to not be judgmental.
Absolutely. So on that note,
Anything else?
We have a question in the comment box. I'm going to read it out to you. It says, with the information provided thus far, where do trans men and trans women fit into this analysis?
Well, certainly sexual behavior is universal, and I don't think it changes from the core in principles that we, or in tenets that we mentioned here today. Is it different? Of course it is, okay? Because negotiating for sex, etc., has to be different. And I am not qualified to talk or to address this. But I must say, there is, not just in HIV, but across the board, and which is very heartening, particularly given today some of the political climate, which is trying to put the transgender person away again. When I do a review of the literature, which I do every year, this year there were, like, I would say 10 times more articles about the transgender populations in HIV, but also in health, more than I had ever seen in my professional career. But is it different? Sure, all things are different, just two different people. But how is it different? Probably not very much, I'm going to guess. It's still healthy. Anything else?
Yes, we have another question. How does this impact our work in regards to PrEP and PEP?
excellent.
I'm going to let Michelle do this one.
Yeah, because very much so. It is utmost importance, and this is where, again, we have created also too, anyone can download our toolkit on how to facilitate these discussions, because another great outcome that I have seen is because of us going into the centers now and speaking to seniors about prevention. Through the prevention, we are speaking to them not just about condoms, but also too about biomedically, and they were very receptive. One, for the said reason, as this one gentleman said, he said, "Oh wow, so this is another blue pill that I can feel comfortable with." And quite openly again, he says, "Well, definitely, I'm going to have this discussion with my doctor." So I truly believe, again, it is there. The opportunity lies there with the discussion and the facilitation of allowing a senior person to be able to express and inform providers out there that they are sexually active, and that should be part of the basis of the conversation.
So PrEP is for all ages.
Exactly.
So, and one of the things that we discovered in our research is that, the woman can be the person who brings the message to the man. It may not be her constant companion, but it could be someone whom they're having casual relationships with and who needs to protect themselves. I mean, the woman who might be positive is already undetectable, so she may not see this as an issue, but she does see the fact that the man who may be having sex with others needs to be protected. And we know that older adults, particularly men, do not use condoms. In fact, condom use drops off almost to zero. And in many ways, they can't use a condom because they can't sustain an erection. And we just mentioned that the pills for keep maintaining erection are costly. So, but PrEP absolutely is important for every age. And one needs to discuss it with their physician or to get information from your local CBO ASO.
Especially those of us also too who have informed our providers we are in disordered relationships.
Great. I know we still have a couple of comments and questions, but we're out of time. So I will forward these comments and questions to Steve and Michelle, and they can follow up with whoever asked them, and I'll also forward their contact information so you guys can follow up.
Perfect.
Maybe we can do sexual health number 2.
Yes. Okay, because there is a need on sexual health.
You got it.
And over 50.
Thank you for listening.
Thank you for having us.
Thank you so much, everyone.
Have a great day. Bye.
And the slides and recording will be circulated after the webinar, so keep an eye out for an email. Thank you.
Great.
Thank you. Bye.
Bye-bye.
Bye.